Hi, I'm Dr. Wickline here with another video. Sorry that you have to hear from me again, but today we're going to talk about what to expect after total knee replacement, and we're going to talk about what medications I frequently prescribe for patients and what they're used for and the pros and cons. So again, I want you to bring your SwiftPath book with you to each visit because what we want to do is on the inside cover I want to write down what medications I'm going to use, what you and I have decided on. I'm going to write them down on the inside so that both my PA and myself, and then also the nurses who are going to help take care of you, know exactly what your plan is going to be after surgery. So in the inside cover, we talk about a number of different medicines. The first one I want to touch upon is something that we use for blood clot prevention. Blood clots are also called DVTs, deep venous thrombosis. Blood clots are something that can occur after knee and hip replacement. And so we want to help prevent that risk so that you can recover as quickly as possible and not have a complication. And so the two most important things are to walk a little bit each hour and of course to do those ankle pumps. But on top of that, I generally have patients use either a blood thinning medication that's a prescription, or ideally baby aspirin. Most patients use baby aspirin unless they're on a blood thinner. So if you're on a blood thinner, please let me know so that I can adjust things accordingly. So that's going to be the first of the different medicines that we're going to talk about. The next medicine is something called prednisone. Prednisone is a steroid. We use a low dose prednisone. I don't want to use big doses because those have side effects, but low dose prednisone can help with swelling and with pain. If you're insulin dependent diabetic patient, then perhaps I don't want to use that, and so we'll use different options. But again, that's something we use once a day for about 3 weeks. Another pill that we frequently use is something called a non-steroidal anti-inflammatory drug, Nsaids. You and I know them as Advil or Aleve or ibuprofen, naproxen. Those pills are great for over-the-counter. They're not really ideal for leading right up to surgery and immediately after because they mess up the platelets. They make you bleed more. And so generally I'll pick either a Celebrex or a meloxicam. Those are pills that are a little safer on the stomach and also don't affect the platelets as much. Those are great medicines to help with post-op pain, post-op swelling, and the achiness. So those are things that we all use when we've sprained our ankle before. Frequently, I have patients take Tylenol 3 times a day. Tylenol is something that's been around for a number of years. I think we all know of it. The generic term is acetaminophen, and I generally have patients pick up extra strength acetaminophen, the 500 milligrams. You'll do 2 tablets every 8 hours for the first 2 to 3 weeks, even as long as a month or 2, because that has really one of the lowest side effect profiles. It helps keep your temperature down. It helps with pain and achiness. I have lots of patients who tell me Tylenol doesn't work for me. In our world, in our data-driven world where we look at science and we look at what pills works, typically acetaminophen, when in conjunction with other pills, makes a bigger difference. So generally, I'm going to want you to take that. So those are the 4 kind of regular pills that we give patients. And then we have 2 other pills that we talk about. One is something called Gabapentin. It goes by a prescription name of Neurontin. It's also generic, just like the other pills that I typically prescribe, so it should not cost an arm and a leg. If it does, you call us. But it should be relatively cheap. And that's a pill that helps with burning. With my wife's cancer treatment, boy, the narcotic didn't help at all, but that medicine made it 80% better within a couple hours. So knee and hip replacement typically will have some burning around the incision, so that pill can make a big difference. It can make you a little sleepy, so sometimes patients only use it at nighttime. Rarely it can make you feel so foggy that you don't really like it, and so okay, you don't use it. The good news about that medicine is that it's non-habit forming, it's non-narcotic, and it won't constipate patients. So I think many patients have told me over the years that it makes a difference. Lastly is the all else fails medicine. That's when we use a narcotic. And in most cases, I try to use Tramadol. Tramadol is about 75% as strong as oxycodone. So therefore, it gives you enough relief for most patients. But again, reduces that risk for hallucinations, seeing snakes, being out to lunch, so to speak, when your coach says, "Oh, honey, I don't want to give you that again. That made you out to lunch." So tramadol tends to be a little milder than the oxycodone, which is my other kind of go-to medicine. Now, in our studies, we've shown that most patients, 86% of the needs, use 10 pills or less. So I prescribe 10 pills. If you need more, you'll let us know. We will potentially give more if there's a good reason for it, but I'm not going to let you get addicted to those medications. So we want to use them sparingly. So lastly, we're going to talk about what the first week, what to expect. Typically, the day of surgery, it's fairly comfortable once we get you through that first stage recovery room and so forth. And you get home, hey, this is pretty easy. The next morning, that first short-acting pain block that I give you wear off. And so the next morning, so say if it's a Friday night, not so bad, I had my surgery on Friday. Saturday morning, boy, honey, it's starting to feel a little more uncomfortable. So that's where you're going to ice it and start getting that bending going. But typically by that night, 36 hours, so in this scenario, Saturday night to Sunday morning, that's typically the biggest pain spike for most patients. So that's where you're going to definitely want to ice it more, maybe back off on your exercises, maybe use that gabapentin as the first choice, and then if that doesn't work, maybe use that narcotic medicine. Then we use a long-acting block. We used to use a pain ball, now we use a long-acting block, and so that will typically wear off around 72 hours later. So that's generally around Sunday night into Monday, and so there may be another spike then. So again, you may need to back off on those exercises and ice it some more. Give it a couple hours, kind of a breather, so to speak, and then kind of get right back at it once your pain is under better control. So again, that's where you might want to use one of those breakthrough medicines. The first choice being gabapentin, last choice, is the narcotic medicine. And then again, lastly, there's this funny thing that happens for patients. Somewhere on day 6 to 8, somewhere in there's a day where the whole leg hits its maximal swelling. And that's where, all of a sudden the calf will hurt. I can barely put any weight on it and so forth. And that's the third pain spike that we see. It's about 8% of the time. So, maybe 1 out of 10 patients, 1 out of 12 patients will say, holy cow, Dr. Wickline, you were right. That 8th day, it seemed really sore, and it seemed to travel right down into my calf and down into my heel. And that's when you're seeing the bruising showing up. So again, that's an expected finding. Of course, you can let us know about it, but just so that you're aware that it's something that does happen not infrequently. So this is the end of this video talking about the post-op pain medications. Again, there'll be other videos, and again, I apologize for you having to listen to my voice so many times, but I want you to get through this with the least amount of pain as possible. Thank you very much.